Just clear line.
Yeah, we are live.
Okay. So good evening, everyone. We welcome you all to the fourth chapter of season 2 of Youthful IRSI. And thank you all once again for being a part of Youthful IRSI. We had a very successful physical meeting at the annual IRSI conference in Chennai, where in fact, there was this new concept of a silent hall. And we had a great 1.5 hour session there and was very innovative and well attended. And now we are back to the webinar front. We've recently had a couple of great webinars from the Bombay Ophthalmic Association, extremely well attended. And I feel that webinars are here to stay because they are always recorded and people can go back. And that's what we've seen over time also, that people go back and then they see it in their free time, and there's so much of learning to be done. So today's topic is of extreme importance and ever-growing and ever-evolving and changing topic, which is premium intraocular lenses. We look back at premium intraocular lenses, and every 3 months we see there's a new lens, new technology, and every single company is claiming that my technology is the better one, it's the best one. So it's really become a little confusing what to trust, what not to trust. And we have a few high volume surgeons with us today who have great volumes and great experience about premium IOLs, and they'll be sharing their experiences about, what are these new IOLs that are in the market and who are the best candidates for these particular IOLs, according to their professions, according to the needs of the patients, because it's all customized nowadays. And so the A to Z of premium intraocular lenses, how to counsel a premium patient, how to treat an unhappy post-surgery patient, and which patient to actually avoid a premium lens, because as they say, you should know what not to do more than what you should know what to do. So I would invite, first of all, Dr. Himanshu Mehta. He's president of BOA currently, to please give us his 2 cents about this topic before I introduce our first speaker.
Thank you, Rohan. Pleasure being with you always with IRSI, a great forum which has been started, the Youthful IRSI session. I guess there was another one, Yossi, which I attended yesterday, something which you did about a year ago on how to start a new practice. I think these are very, very important things that a newcomer should go through again and again and again and again. There's so much to grasp. Yes, the Chennai conference, what you did was absolutely fabulous. Dr. Dua sat through the whole meeting. Dr. Abhay Vasavada was there. Suhas was there. Everybody sat through. Everybody enjoyed. Lunch was being served over there. And all those personal questions which you could never ask otherwise in an open audience was the one which were addressed. And a great bonding which happens with all those speakers too. They were also feeling very comfortable. In fact, I would say in the beginning, the speakers were there in time. The others were late. That's how much they were enthusiastic. Because this is one of the best sessions attended in the US, in the academy, in the ASCRS, and at the ASCRS, wherein you have a great opportunity to meet all these senior people and give their opinions on that. Excellent. Keep it up. I think it'll pick up momentum very soon, and it's a great idea. With regards to today's topic, this is the burning topic today. To me, there is nothing like premium IOL. Everything is a routine. It should be there in every patient. Every patient deserves very good vision, and they all want very good vision. And this idea in our mind where the company has put up the word premium, there's nothing premium about premium. These are mandatory stuff which should be there. Like air conditioning was premium way back 30 years, 40 years ago. It's not. A motorized car or your steering wheel, all that is normal. This is nothing premium about anything anymore in life. So also we have great speakers today. Dr. Nitin Balakrishnan, a very senior renowned surgeon with great volume and excellent in-depth study about most subjects. He would be sharing his knowledge. And of course, Zain, our young innovative partner, who has a lot to contribute, who got his ASCRS award. And really nice to have them to speak to us about what's happening with the premium IOL. What are the newer lenses that they have for the patients to afford and to attract them, to get them in their eyes, Because at the end of the day, whatever you say and whatever you explain, the patient is going to tell you, Doctor Saab, aapko jo lage wo karo. After all that 20 minutes, 1 hour of explaining and putting your head there, they are going to tell you, Doctor Saab, aapko jo lage wo karo. That's the whole thing, because the blame will come on you. And how, once they have put the lens, how unhappy they are or happy they are. Remember one thing, like all the comments in Google also, when they are unhappy, they'll write. When they are happy, most of them will not write. So this thing about the rings in the lens, if 2 people out of 1,000 complain, but it's given the maximum importance, unfortunately, and 998 people suffer because of that. And so also the common thing in day to day, we all keep suffering with whatever problems with the potholes in Bombay. Nobody wishes to complain and we all have to suffer. And that's how this life goes on. But yet they don't complain. And here with 2 rings, they complain. So, well, let's hear what they have to say. Over to you, Rohan, and have a great evening. Wonderful to have organized this meeting.
Very warm welcome to Dr. Poornima Jain from Jaipur. And I'll ask Dr. Pooja to please introduce our first speaker now.
Thank you, Rohan. Thank you, Dr. Mehta, for your kind words. And we definitely will learn a lot from this webinar today. We now welcome our first speaker, Dr. Nitin Balakrishnan. He is the Medical Director and Chief of the Cataract and Refractive Department at the SII Eye Clinic and Crystal Vision Laser Center and has been in practice for more than 30 years. He has undergone training in phacoemulsification from international stalwarts in the field like Dr. David Chang from the United States of America. He specializes in laser vision corneal refractive surgery and is a member of the expert group of Contura LASIK surgeons of Asia Pacific. He has been on the faculty and has presented presentations on various national and international conferences. We are so grateful to have him here with us to talk about how to exactly deal with unhappy premium IOL patients. Over to you, sir.
Thank you, Pooja, for that introduction. Shall I start with sharing my screen?
Yes, sir.
Yes, sir. Yes, sir.
Okay, right at the onset, I entirely agree with what Dr. Himanshu Mehta said about the premium IOLs. I think the word, even in this topic, should be changed to dealing with unhappy post-op patients, not unhappy premium, because today everyone is a premium patient. For that patient whom you are treating, you can't differentiate between just because he's paying you a few thousands more, you can't call him a non-premium. For him, it is his eye, and that eye of his, the vision of his is important. Over a period of time, we've been seeing quite a few newer IOLs coming in. I'm sure Zain will be elaborating more on them. But then, in the definition of premium IOLs, what people call premium IOLs, they limit it to things like torics, the trifocals, the multifocals, the EDOF lenses, and the accommodative lenses, which are not being used anyway today. But I would say these are what, by definition, the companies would want us to believe are the premium IOLs. But then even the other monofocal IOLs, I think, do fall in the same category of premium IOLs because, like I said, for the patient, his eye is the premium eye. So basically, by definition, we would call any IOLs which are responsible for giving you a spectacle-free vision for both distance and near would be classified as a premium IOL. Now, in spite of doing all the major tests which all of us do for premium IOL, for any IOL, that is an optical biometer, the topography, image-guided system, planning system, the aberrometer, specular microscopy, and whatnot, we still have these patients who are unhappy at the end of the surgery. In spite of an excellently done surgery, in spite of a very clear cornea on day one, patient's vision is good, but still you find that these patients are not happy. They always have something to complain about. So how do we increase the 20/20 happy patients and decrease the patients who are 20/20 unhappy? So basically, the first and the foremost thing is a careful patient selection. Now, this would include finding out the patient's job profile, his hobbies, his habits. They are very important. Just because a cataract patient comes in the 60+ age group, don't consider him to be don't consider that it's not important to deal with his hobbies and his habits, and they may be still in active sports, they may still be trekking. So it's important that even these patients, you consider not only their job profile but also their other things what they do in life. Again, personality traits, understanding the personality trait is a very, very important thing for counseling a patient into any of the lenses. For example, a highly demanding patient, or is the patient a happy and a contented patient? The highly demanding patient would want everything the best. And he would assume that just because he's paying you an extra premium, this lens should be the lens which has no other problems. That is not always the case. So it's important to understand the personality traits. Always beware of patients who say, I want the most expensive lens. Because he thinks that it is just like an Audi or a Lexus, that if he pays for that, he will get something which is absolutely fine. He doesn't realize that there are potholes, like Himanshu said, on the streets of Bombay. And even a Lexus will make you uncomfortable. Again, appropriate counseling of the patient is very important. And here it's important to get in the caregiver. The patient's relative, his immediate relatives are very important, that they are there during your counseling. The patient may just nod at everything what you say. He may at times may not even understand all the things. And it is the relatives who would then post-operatively come and cause problems, saying that this is not right and that is not right. So it's important to involve the immediate relatives or the caregiver of the patient during the counseling, and see to it that that caregiver understands everything. Again, it's very important to set very realistic expectations of what can be achieved and what cannot be achieved. Again, like I said, just because a patient is, the entire mindset of the patient needs to be changed from the fact that since he's paying a lot, it is the best and it is a problem-free lens. No, every lens will have its own problems. So it's important to set realistic expectations and make the patient understand the pros and the cons of each and every lens for which you're counseling the patient. Now, again, patient selection, like I said, is very important, is occupation. So if especially you have a patient like a watchmaker or a diamond merchant, these are just a few examples which I'm trying to give you. If you want to put in a multifocal lens for this patient, you would prefer a trifocal, because this patient is not dependent on an intermediate vision, because he needs a very close vision. On the other hand, if the patient's occupation is something like a pilot or a truck driver, a trifocal or a bifocal lens would definitely not be in, because he would have all the other problems with these lenses, like the glares and the halos. So again, jobs requiring activity at night or under low light conditions, choosing a diffractive or a refractive multifocal IOL increases the photoptic phenomenon in dim environment, and therefore one needs to counsel these patients for an EDOF lens with a micromonovision if required. Again, patient's age is very, very important. Remember that there are several conditions which are prevalent with advancing age, like macular degeneration, optic neuropathies, ocular surface diseases. And all these things would cause a loss of contrast sensitivity, especially if you use the multifocal IOL. So if one needs to rule out all these things before you counsel the patient for a multifocal IOL. It's important to evaluate the ocular surface, because MGD, dry eyes, blepharitis can cause problems post-surgically, and therefore these need to be treated either medically or with an IDRA or with a LipiFlow or a EI treatment, so that's the IPL treatment, prior to surgery, and not telling the patient after the surgery that he had dry eyes. So it's been proved that pre-existing dry eyes is aggravated by the inflammation, by the reduction in goblet cells due to the surgical time, the incision size, the hardness of the lens, and post-operative eye drops which are not preservative free, and therefore these all give rise to suboptical surgical outcomes. And therefore, if a dry eye of a patient is not treated preoperatively, please see to it. Due to any reason, maybe patient does not have time to get the dry eye treated. He wants the cataract surgery done immediately. He's traveling abroad. Or if a patient has a hypermacular cataract, you don't have time to deal with his dry eye, then please do not use a premium IOL in these patients, especially the ones which have severe dry eyes. Again, a thorough ocular examination is very important, right from the tear film to the macula, the ocular surface, corneal topography, good specular microscopy, aberrometry, a biometry with a proper formula is all important, along with a retinal examination with an OCT. Personality traits of the patients are very important. Like I said, initially unreasonable expectation patients, patients with anxiety, doubt, or nervousness, or a perfectionist who wants absolutely everything, who has an obsessive compulsive disorder. These are the patients who are most likely to be dissatisfied with the presbyopic correcting IOL. Patient counseling, so basically simply educate your patients about what the IOLs will and will not do for them. Let them make a decision. Like I remember Kerry Solomon had once mentioned that you can be part of the counseling. You can help the patient make a decision, but do not make a decision for them, because very often a patient will come and tell you, "Aap jo samjho wo dal do. Whatever you feel good is for me, you put it." That is not the way to go. The patient has to know that these are the side effects and let him make the decision. Do not make a decision for the patient. Be a part of the decision making, help him out to make a decision, but do not make the final decision for the patient. Again, be honest and realistic. Most important thing is to inform the patient that there is no man-made lens as of today. Probably it will not even be manufactured even in the future, which is as precise or which will give you as clear good vision for all the distances, like the natural lens, especially at the age of about 25 to 30. Patients generally consider issues described before surgery as expectations. But if these same issues are discussed after surgery, they would label it as complications. So remember this, that it is better that you explain all these problems before the surgery and not after the surgery, that these are known things, or you should have known about it. These are the things which the patient would then treat that it's a surgical complication, though it is not one. So understate the benefits and overstate the side effects of the IOL. This should be your mantra in your daily counseling. Always see to it that you promise less and deliver more. If your promises are more and you cannot deliver them, these are the patients who are going to be troublemakers for you later. So understand the patient vision needs and desires. Carefully discuss the strengths and the weaknesses of each and every lens that will be used. Now, patients are often now, for example, now in case when I'm using an Vivity lens, sorry, I don't have any financial interest in any of these brands, but these are the commonly used lenses which we would use for presbyopic correction. And so if I'm using a Vivity lens, I would definitely emphasize that the patient will get only functional near vision. I would tell them the need for a micromonovision and maybe even a need for a small reading aid, especially for reading fine print. If I'm doing a bifocal lens, I would tell the patient that he would need near vision glasses to read a computer, or he would need to go closer to the screen to use the computer. In case of an enhanced monofocal IOL like an IHANS, I tell the patient that he will definitely need glasses for near work, especially for fine print, as fine as something like the share prices in the Economic Times, or maybe the expiry dates on the drugs. So these are the cases where he would need glasses. So it's important that all these things be mentioned to the patient to prevent a problem post-operatively. So I'd like to give a few examples now. This is a patient, a 60-year-old patient, wanting to go for a multifocal IOL. He's had an RK done 30 years back. This is his pentacam finding. Nothing specific. He's got a flattening in his keratometry. Now, as you can see here, the EKR65 mean is not very skewed. Whereas if you see the histogram over here, you see there's a wide skewing of the histogram distribution. And therefore, such a patient would definitely not be happy with any of the presbyopic correcting IOL. So these patients should be avoided whenever you're planning. So don't counsel this patient. Tell him that a presbyopic correcting IOL, a multifocal IOL is not for him. Again, another example of a patient who has undergone a previous refractive surgery and wants freedom from glasses. Again, most of these patients would want freedom from glasses because they're used to post-LASIK not having used glasses. Now, again, as you can see here, the EKR map shows that there is hardly any skewing between the 2 millimeters to 5 millimeter zone. And if you see the histogram here, it is not skewed. We have tall peaks over here. The EKR mean is less than 1.2, and the difference in the 2 to 4.5 millimeter zone, which is a patient which can undergo a premium IOL or a multifocal IOL. Again, another example, you have this patient who is a 55-year-old a patient, a stockbroker who drives back home after his work, and usually it's late in the evening with the headlights on. So what would be a choice of an IOL? Here, I would definitely not convince this patient or try to dissuade him from any of the IOLs which are diffractive or refractive multifocal IOLs, and I would go in for an extended depth of vision IOL like a Vivity or any other brand which is available with a micro monovision of over 0.5 to 0.6 diopters in the non-dependent eye. Again, when you have a patient with a poor specular microscopy like this who wants a multifocal IOL, remember that you would, in spite of doing a phacoemulsification with a good viscoelastic, multifocal IOL in these patients may not be recommended, primarily because this patient may need to go in for a corneal transplant later, and most important thing is higher order aberrations will be very high, and even with a good Snellen's vision, this patient is not going to be happy. Another example is now we have quite a few of the presbyopic patients who are hyperopic and even with a clear lens want to go in for a clear lens extraction. Now, with a dysfunctional lens index like in this case of 3.45, so this patient definitely has a dysfunctional lens and can go in for a clear lens extraction. But here, the IOL of a choice here, since this patient wants to enjoy vision at all the distances, this patient could be a good patient for a trifocal IOL. However, the same patient is a patient who regularly drives, who does long distance driving, or who does road trips often and would drive in the night, then extended depth of focus vision would definitely be a better choice than a trifocal IOL. So again, when you're putting in a trifocal IOL, explain about the neuroadaptation and tell the patient that it could take as many as 2 to 3 months for him to get neuroadapted. Again, it's very important to explain to the patient that neuroadaptation is very simple if you do a bilateral cataract surgery. With a uniocular cataract surgery, a neuroadaptation is going to be slow process, and therefore convince these patients that they can go in for a bilateral surgery at a very short interval after the first time. So, in short, all these lenses should have horses for the courses. Do not give the patient a choice of only very few IOLs. Let them have all the choices. But most important thing is help them make a decision after explaining the pros and cons. And careful attention to managing the patient's expectation is therefore very essential for overall success. Thank you. Thank you for your kind attention.
Thank you so much, sir. In your experience, how much of negative dysphotopsia have you seen with multifocal IOL, sir? Like, you see a lot of patients not only in monofocal but in multifocal more so, or is it less in multifocal IOLs where they say that that shadow is coming from one side?
Rohan, what I have seen basically is with the glares and halos, when they are troubling the patient, they hardly complain about the negative dysphotopsia. The monofocal IOL patients don't have anything else to complain, so the negative dysphotopsia in them is more prominent. But in multifocal IOLs, I hardly have any patients either with a EDOF or with a trifocal who complain of negative dysphotopsia.
Dr. Zain, your view on this negative dysphotopsia in multifocal or trifocal lenses?
Correct. In my experience, I have not had a single patient who've complained of negative dysphotopsia in a trifocal.
So would you think that has got something to do with the design of the lens? Like when it comes to a monofocal and when it comes to multifocal, maybe the apodization does not let it come or something like that?
No, I don't think so. I mean, it's well established now. Negative dysphotopsia happens because, of the square edge and all that. Probably what Dr. Nitin said is correct. It's the, halos that come with the diffractive optics that, drives away the attention from the negative dysphotopsia.
Excellent. Dr. Manshu, sir?
Complaint is a standard phenomenon with monofocal, multifocal lens. I just had a patient, lovely patient right now. I loved it. She put up a complaint for I can see very blurred. Then gradually shed some time, which means 95% of the time she was seeing well. But she didn't mention that. She mentioned just this part, where she wanted to complain. So this is the standard scenario with most patients. They just have to crib about something. They'll never say anything good. They say that is, of course, taken for granted. Hey, I can see. You see how they complain. What is the biggest complaint, Rohan, after surgery? Tell me. Is it halos, glare, whatever? No. It is khatakna. Khatakna. Aankh khatakti hai. वो लेंस बाहर खटकता है. That is what they have there in their mind, that lens khatak raha hai. Now you can't just escape this nonsense. They have to crib about something. So the biggest healer is time. You just have to pass time. And not a single negative dysphotopsia patient of monofocal have I had to remove a lens or do anything. You just have to buy your time. It's just that I tell them only one thing practically, that with glasses you are having only vision till here. Now your vision is extended beyond to 180 degrees. So you're seeing more than what you're supposed to. So you're not able to adjust to that. And then they realize, yeah. My field of vision has increased. Earlier I used to see this much. Earlier I could not read all these things. Now I'm reading. Okay, now go on the positive part. But that's move on in life.
Very well said, Himanshu. But I think that is basic human nature. If you read any of the Google reviews for any of the restaurants, most of the reviewers would say that the food was excellent, but they would still give a negative thing because the waiter dropped a drop of water on this pant, or probably the water was not chilled enough. So I think it's basic human nature to complain, and we have to live with it. Only thing is we need to learn how to adapt to it and how to solve these problems.
One question I have for Dr. Poornima, since they do a lot of cases there up in Jaipur. The question I have for you is that in case there is an unhappy patient with a particular IOL, do you offer them an IOL exchange? And when is that you offer them an IOL exchange? And is it true that, at least in our practice, what we have noticed is the moment you offer them an IOL exchange, everything just gets back to fine?
Actually, we hardly give them the option of IOL exchange. First, the thing is to have, we have to motivate the patient and give reassurance. That's the main thing. If you give chair time to the patient, if you give reassurance, half of the battle is won. You have to talk to the patient. You have to listen what are their complaints. Even if you know they are about to complain, you have to listen. And once you listen properly, half of the time they are satisfied that you have listened. And you have to just counsel, and giving reassurance is enough. Because IOL exchange is itself a complicated process, and it's the last resort. Unless the symptoms are very high, or there is post operative, there is a refractive surprise only for the contrast or dysphotopsia or higher order aberrations, I think none of us go for the IOL exchange thing.
Right. So, sir, Dr. Nitin, sir, there was a particular slide and example that you gave about a stockbroker who has to see multiple screens. And in that patient, you would put a eye-hands lens, and you would not put any lens with a rings or even a Vivity. So why won't a Vivity work in such a patient who has to see multiple screens, sir?
So I just mentioned EDOF lenses. So probably there was any of the EDOF, even a Vivity would do. Again, I have found that some patients, because of the central bump in the Vivity, do have a slight problem at night, especially for a month or so while driving. It's not as severe as in the trifocal. Probably that can be explained by the central bump, but it's not as severe. It's not a significant thing. So for these patients, I would give them an option. Definitely a Vivity also would be an option. Any of the EDOF, definitely not any of the lenses in the ring.
Okay. And sir, what about post-LASIK? Like in post-LASIK, you very well showed the EKR maps. But if you find that the EKR maps are fine, like there's nothing wrong with them, then in a post-LASIK case, would you have no hesitation in putting a trifocal?
I would not have an hesitation after I'm sure that the patient has understood that there could be a very high chance of a refractive surprise. I tell the patient that this is a mathematical formulae which are calculating his lens power, and because of the change in the corneal curvature, one cannot be sure that we would hit the target. Again, I think one slide got missed out from my presentation is the importance of an angle alpha and angle kappa in these patients, especially when you want to go, especially with an angle alpha more than 0.5, one needs to be very careful while putting in a multifocal lens.
I think Zain will cover that in his presentation. So now I'll move ahead. Our next speaker is Dr. Poornima Jain. She's a practicing consultant at Anand Hospital, Jaipur. She has presented multiple papers on national and international conferences. Dr. Jain is here to talk to us upon when not to put a multifocal IOL, absolute and relative contraindications. Over to you, ma'am.
Thank you so much. First of all, I want to thank all of you and especially Dr. Pooja Mehta, ma'am, to give me this opportunity and I am obliged to presenting here in front of all of your dignitaries. It's my first experience with all of you.
Thank you, ma'am. Please share your screen.
Yeah. Is it visible?
No, not yet, ma'am.
Not yet.
Just a minute.
Ma'am, there is a tab share screen on this Zoom panel. Yeah, you have to click that. Yeah.
Ma'am, if you're having a little difficulty, we can go on with Dr. Zain and then we can come back to you.
I think that would be better, I think.
Okay. So we'll just have Dr. Zain, a young dynamic consultant ophthalmologist at Khatib Eye Clinic and Perfect Vision Laser Center, Mumbai. He has recently won his video at the recent ASCRS Film Festival, USA. Today, he will talk to us on decoding EDOF lenses. How do they work? Who are they suitable for? Over to you, Zain.
Thank you, Dr. Pooja, Dr. Rohan, Himanshu sir for inviting me to speak here. So just let me know when my screen is visible.
It's visible.
All right. Okay. So I'll be speaking on decoding EDOF lenses. This is actually a topic which I like a lot because I'm always trying to find out these new EDOF lenses, what exactly is the technology it's working on. And it's actually a vast topic because there are so many EDOF lenses today, and the maximum research on IOLs today is going on in EDOF lenses. The reason why EDOFs are getting so popular is because the problems we've had with diffractive IOLs, as Dr. Nitin sir said, the dysphotopsia, glare, halos, there's no solution for that. So that is there and that will always be there because diffractive optics will always have that. So our quest for the perfect presbyopia IOL is continuing. And according to me, there are 4 parameters today based on which we should judge a presbyopia correcting IOL. The first is the depth of focus. It should have a good depth of focus. It should be good for computer, for reading, for phone, for everything. It should have no or minimal dysphotopsias, that is the glare and halos. It should have a good contrast. So when we say good contrast, when we are talking theoretically, we're talking about something called as modulation transfer function, or MTF. And practically, when we talk about good contrast, we are talking about low light performance. And it should be cost effective. So, because there is so much of technology these days that the cost of the lenses sometimes goes really high, and you realize, it may not be that much worth the price. So the problems we encounter is that anytime you want to increase the depth of focus of a lens, whatever you do, you are going to cause some problem, dysphotopsia, or you're going to reduce the contrast. We don't have technology which can increase the depth of focus and not have these things. And suppose you want to reduce these side effects, the depth of focus also reduces. So nowadays we have extended monofocals which work on this principle, where they reduce the depth of focus but also reduce the side effects. And suppose there is a lens which manages to increase the depth of focus with minimal side effects, the cost is really high. So, we have to work around these problems. And based on that, the EDOF lenses are constantly evolving. So if you talk about the definition of an EDOF lens, this is the American National Standard Institute definition of an EDOF lens. We won't go into the details, but if you look at the defocus curve, which is right down, you can see the green defocus curve is of a EDOF lens and the blue one is of a trifocal. So it shouldn't have the bump of the trifocal, like the camel hump, which the trifocal has. It shouldn't have that. It should be continuous. That means a good depth of focus. And at the same time, it should be above the monofocal, which is black, to tell you that there is, better reading for intermediate and some for near. So, anytime the company guys come and tell you they've introduced a new lens, they'll show you a brochure which will have a photo like this. They'll show a stretched depth of focus and they'll tell you that this is what the lens does, and it gives N6, N10, N8. They talk things like this, which actually don't make sense to me, because we need to understand the technology, how it is happening. Based on that, we can make a decision. We have such a wide variety of lenses. So this is what I'm going to try to do to the best way possible in this presentation. I'm trying to decode the different lenses that are EDOFs and what technology they work on. So the first one is diffractive technology. The second one is modest refractive changes. The third would be spherical aberration technology. The fourth is optical elements. And the fifth is progressive IOLs. Now, most of the lenses we have today, they fall into one of these 5 categories. But of course, there are lenses which are outside. But the common ones that we use, and I have no financial interest, but they will use some technology or the other. So let us start with the first one, which is diffractive technology. Now, we all know this is the technology which has been used for the diffractive trifocal and bifocal IOLs, where diffractive steps cause another focal point to be created. So for trifocals, you have different height and width of the steps, which give you 2 additional focal points. Now, an EDOF lens, which is based on diffractive technology, includes Symphony and At-Lara from Zeiss. Now, they have made modifications to these steps. They call it an HLA design in Symphony, and they call it a phase zone in At-Lara. But the point is that whenever there is diffractive steps, it can't be a true EDOF. It will always be a pseudo EDOF, because you can see that bump in the center. So by changing the height of the steps, you can get the focus closer to the distance vision, but you can't avoid the bump which comes in the defocus. So as a result of that, you will get a good depth of focus, but the dysphotopsia problem will persist. However minimal it is, it will always be there. There'll always be some contrast issues, and the cost of these lenses also used to be higher. So the diffractive based EDOFs were in the much earlier days when the newer technology was not, was lesser, but now the companies have moved away from diffractive EDOFs and they are moving towards non-diffractive optics. Let's talk about the second group, which is the modest refractive changes. Now, the first lens that comes here is the Technis Eyehance lens. If you look at the Eyehance and you look at a normal aspheric Technis lens, what you can see is in the center, there is a ever so slight increase in power. And this power increase is very less. It is not very pronounced. So what this lens does is, when you have a pupil which is mesopic for distance, this small power increase is not going to affect the vision. But the moment you get a reading add and the pupil constricts, that increase in power will give you some additional depth of focus because of the increased power. And this helps in increasing the depth of focus for near, as can be shown in the defocus curve of the Technis Eyehance versus Technis multifocal. But this increase in depth of focus is so minimal that it actually doesn't affect the contrast that much. So you can see in the Eyehance also, the modulation transfer function for distance is above 0.4. Now, anytime the modulation transfer function is above 0.4, there is very minimal loss of contrast. So this lens does well in the sense that it works like a monofocal with respect to side effects. They are very less, no glare, halos, no loss of contrast, but the depth of focus is limited. So based on a similar technology, another company came up with a lens, Magnificent, which is from IOCare, which made this increase in central power more pronounced. So if you see the design of this lens, you can see in a 21 diopter lens, which is the green map, you can see in the center, the power has increased quite significantly. So you can see orange in the center, which goes to 22.5. So you've got almost a 1.5 diopter add in the center, but in a gradual way. It is not kind of a refractive step, but gradually it increases from 21 to 22.5 in the center. And as a result of that, for near vision, you get very good results. So if we judge this lens based on our parameters, depth of focus with eye hands is not so good, much better with magnificent. Dysphotopsias are not there in both. Low light performance is good in both, but magnificent, it is questionable because you've got such a change in power. The cost is very good. Magnificent is especially a very cheap lens. But one thing you should be careful about magnificent is that you have to be careful in a small pupil, because if pupil is small, the patient may end up becoming myopic because of the high power in the center. So I would not implant it in a patient with small pupil. Coming to the third technology, which is spherical aberration. I'll spend some time on this because this is a really important thing, and most lenses nowadays are doing research on this. So when you say spherical aberration, if you look at the rays in yellow, they are called as the peripheral rays, and the rays in green are called as the marginal rays. When the peripheral and marginal rays, they focus at a single point, this is called as zero spherical aberration. But if the periphery of a lens is more curved as compared to the center, then the peripheral rays will be stronger than the marginal rays. This will increase the depth of focus, and this is called positive spherical aberration. Similarly, if the periphery is less curved as compared to the center, again, the depth of focus will increase, but this is called as negative spherical aberration. So this increase in depth of focus has been utilized by IOL companies to make an EDOF lens. Now, how much of spherical aberration can you induce in a lens? I'm sure it cannot be unlimited. So this study by Rocha et al. Shows that both positive and negative spherical aberration up to 0.6 microns gives a good depth of focus, after which the depth of focus starts, is kind of toxic and it doesn't increase. Similarly, when we do LASIK, we are inducing positive spherical aberration. So this old study conducted by Reinstein et al. Tells us that even if you do LASIK up to 8 diopters of myopia, you induce about 0.56 microns of spherical aberration, which is up the limit. So you can't go more than 0.6 microns of spherical aberration. Beyond this, the contrast will go down. And you can see in this other study, it shows the depth of focus with 0.3 and 0.6 micron spherical aberration. 0.6 is almost double. And similarly, in this chart, you can see, again, up to 0.6 plus or minus is normal. Beyond that, it is toxic. So we want to get somewhere around 0.5 to 0.6 micron spherical aberration for best depth of focus and non-toxic. So now what should the IOLs do? One very important factor is the human cornea, which already has a positive spherical aberration of around 0.3 on an average. So if you have an IOL, which is giving you little more, say 0.15 or 0.2 microns of positive spherical aberration, along with the cornea, you get a decent depth of focus of around 1.25 to 1.5. So this is what the Rayner lens does. In the center, it slightly increases the positive spherical aberration of 0.15. And if the cornea has a good spherical aberration, you get a good depth of focus. So this has a good depth of focus depending on the spherical aberration, no dysphotopsia, good low light performance, because we know that the change is so minute and the cost of this lens is also good. But what if you want to have a lens which gives you more depth of focus independent of the cornea? So for this, we need to little bit understand about this Zernike's pyramid. So you can see these three, Z20, Z40, and Z60. Z20 is called defocus, 40 and 60 are primary and secondary spherical aberration. So why we need to understand this is because if we look at the 2, 4, and 6 values, these are the number of slopes along the meridian. So let me explain this to you. The above diagram is what you can see with no spherical aberration. So this is defocus because it's got only 2 slopes. But on this surface, if you induce primary spherical aberration, which has 4 slopes, as you can see, and the diagram which I showed and the Rayner lens, which it is based on, will give you some depth of focus because the periphery focuses in front of the center. But if you now induce 6 slopes on the same surface, as you can see, 1 and 6 have been added. So this same surface at the periphery now will have 2 slopes, one more curved and one less curved. So the periphery will have 1 point focusing behind and 1 point focusing in front. And this increases the depth of focus. It makes it double. So this is another study which shows you that if you induce plus 0.3 of Z4 and minus 0.3 of Z6, you get the maximum depth of focus. So there are two lenses based on this technology, MiniVel by SII and Lux Smart, which work on this technology. They have a good depth of focus independent of the cornea, good dysphotopsias, but low light performance and contrast is again questionable because you're making these kind of optical changes to the surface. These lenses are relatively higher priced. And again, small pupil, you will lose the effectivity because you need at least 3 to 4 millimeter pupil to enjoy this depth of focus. Coming to the next one, which is optical elements. Now, these lenses are Lucidis and Vivity. Coming to Vivity, they actually put in optical elements on the surface of the lens. So this ring you can see on Vivity. How does it work? It's a very elegant way of increasing the depth of focus. If you look at a normal lens, when there's no spherical aberration, the wavefront is the red curved surface which focuses at one point. Now, the moment you introduce this optical element, you see the wavefront has got distorted with two bumps. And as you go closer to the focal point, instead of focusing at a point, it forms a stretched out kind of wavefront in the center because of that central bump. And this gives a good depth of focus. Similarly, Lucidis lens has a central optical element, which is called as pseudo non-diffracting beam, which is independent of the rest of the periphery. And this depth, central beam, it increases the depth of focus independent of the distance. So again, these have good depth of focus. Low light performance is questionable in both these lenses because, you know, anything which obstructs or changes the shape of the natural wavefront is definitely going to reduce contrast. Vivity again is an expensive lens, and Vivity again you have to be very careful of small pupil because in a small pupil it will not work. It will like completely fail since the optical element is in the mid periphery. Coming to the last group of lenses, which is progressive. There is one lens made in India, which is called Autofocus Pro by two Indian ophthalmologists. Everything is very good in this lens. It's like a progressive lens. But the only thing in my experience is the depth of focus it gives is kind of questionable. Sometimes it works, sometimes it doesn't work. So basically, just to summarize, the EDOF lenses are very vast. I've tried to cover it, in a short period of time. But my algorithm is such that if I have to do presbyopia correction in a patient, if he is not doing night driving and if he doesn't have a type A personality, trifocal lens is still a very good choice. But if any of the answer to this is yes, then I will move away from trifocal. If he has a good corneal spherical aberration of more than 0.3, the Rayner lens works very well. It gives a good reading and you can do micro monovision depending on the first eye. But suppose the corneal spherical aberration is low, then if the pupil is more larger than 2.5 or smaller than 2.5, my choice will change. If it's larger than 2.5, cost is not a factor, I'll go for Vivity. If it is less, if cost is a factor, I'll go for Magnificent. And if the pupil is less than 2.5, cost is not a factor, then we'll go for Lucidis. If cost is a factor, then Eyehance with micro monovision is a good choice. So that was a little bit about the different technologies used for EDOF lenses. Thank you once again.
Zain, that was an extensive, in-depth knowledge about the EDOF lenses. Thank you so much. I just wanted to ask you, one of our viewers has a question. Do you have any experience with the Autofocus Pro that you had mentioned?
Yeah, I've implanted few lenses of the Autofocus Pro. It doesn't do the primary job that I feel it should do consistently. Meaning it doesn't always give me the near vision that I expect it to give. Like, you know, the other lenses, they will tell you that, okay, I can understand the science of how it should work. But with Autofocus Pro, I don't understand. Sometimes it works, sometimes it doesn't work at all. But the side effects are very minimal. So it's like a hit and miss. That is my experience, but others may have better experience with it.
Yeah, actually, I've had this same experience with the Magnificent lens also. It's been a hit and miss on a lot of occasions. So in a lot of your presentations, beautifully explained. I mean, this is just a thesis on EDOF lenses that are there till date. I mean, if we go back and look at it again and again and again, I think there's nothing stopping us from becoming masters of it. Looking at your presentation, you were talking about the size of the pupil, small pupil. So what exactly is a small pupil? What is the measurement of a small pupil according to you?
So, see, I would say for if you have a mesopic pupil, oh sorry, not meso, if you have a photopic pupil, which is less than 2.5 millimeter, I would call that as a small pupil. So if you see the magnificent lens, they have shown you that where exactly they've given the additional power. So if they've given a very large step of additional power in the center, so if the pupil is small, it won't give the depth of focus. It will just make the patient myopic, because you need that aberration to, you need that change in power to act.
And that's what I have felt with this magnificent lens. The patient's distance visual acuity goes down. Like these guys, they become 6'9" instead of 6'6". Although thankfully they were not complaining because there wasn't a need for that much of vision for them. But yeah, I felt that in a lot of cases. So it might be possible because of the pupil size. Dr. Nitin sir, your 2 cents on EDOF lenses. If you're there, Dr. Himanshu sir.
Yeah. Then that was a great presentation, probably an eye-opener into so many things about the physics of the EDOF lenses. Well, I've been using EDOF lenses, like I said, in those specific cases where the glare halos are a problem, those particular patients with specific occupations. They work very well. The only problem is the near vision and the need to wear those small reading glasses as an addition. Very often patients are not willing, especially if they've gone for a premium lens like Vivity or one of those premium lenses. They are not willing to accept the fact that they will need to wear glasses in spite of going in for these lenses. Otherwise, these lenses do very well, especially with a little bit of micromonovision. In my experience, they're great lenses to use.
Excellent. Dr. Manju, sir?
Yeah, excellent. Zain, as usual, brilliant presentation. You know, something which we are so worried about, spherical aberration and all kinds of aberrations that we try to remove, is the one which they are using in the present lenses. The extended depth of focus which you have is all because of the point focus which is extended. You know, the Sturm sphenoid, if you understand the good old Sturm sphenoid which we had, and which is so very well exploited by these modern lenses. They have done a great job. And as I said, there is no one particular answer to anything and everything. You should be convinced which lens are you using for which person. That, as he said, it's as the other one which he said, hit and miss. I totally agree with him. Small pupil, be very careful of using any kind of multifocality in a small pupil. It can come and hit you. That's one thing you should have to. The angle alpha and the small pupil. Well, the synergy kind of a lens has a bigger optic for reading. So it's a little more surgeon friendly. Even if you have a little angle alpha, it works well. So that's how I would put it. But excellent summarization of various lenses. I think that is what is required to understand the physics behind the lenses and why one is preferred over the other. Then thank you so much for your time.
Thank you, sir. Thank you.
Then your experience after putting an EDOF lens in a patient and then their experience on the mobile phone, because a lot of patients that I put EDOF lens in, they've said that, we don't really need that glass. Yes, we just have to push it away a little bit and it becomes clear. So that range actually, it's more than 33. It's about 60 where it's clear. So do you prescribe any glasses to these patients as such, or you say just let them be and they will neuroadapt and focus the distance according to whatever they are comfortable with?
See, that is actually a very valid question. And I have seen this, most of the people nowadays, they don't, unless they are an accountant, they don't actually have that much of reading newspaper and all. Everyone sees their phone. Now, the thing about the phone is the contrast is extremely good. So I personally don't generally, give a reading ad for an EDOF lens. Most of the times, the EDOF lens does the job without a reading ad, is for mobile phones. So most of the patients who want to work on the phone or want to play games on the phone and all, they do well with a EDOF lens. Even a EDOF lens which doesn't have the best depth of focus, they do well because the contrast of the phone is so good. That makes a very big difference.
Yeah. And they always come and say that, little bit we put it on the side, just like a presbyopic would come and tell you, if I do it this way, then it becomes better. That's exactly what they say. And a lot of them come and say that.
So the answer to majority of your problems with all these multifocality contrast is solved by more light. And as I tell patients to switch on the light on your cell phone when they are reading something, easiest thing. Menu in a restaurant, for all presbyopes becomes very easy with the light on your cell phone. So the moment you have more light, all those problems are just taken care of.
Everything is switching to digital, so that helps us. Even restaurants are coming on tablets and iPads, so that light is naturally there. So that is a very big advantage.
Yeah. Thank you so much. Dr. Poornima, ma'am, you're ready with your presentation?
Yeah, I am really sorry for actually I accidentally switched off the thing.
No problem. Yeah.
Now is it seen?
Yes, very much so, ma'am.
Okay. Since my topic is about the multifocal lenses, about the relative and contra, means when not to put the multifocal lenses. And this topic already almost 50% is covered by the Dr. Nitin and Dr. Zain. So not much to say for me because they have already addressed why the people are unhappy. So if we address why they are unhappy and when not to put and to see for the contraindications, half of the job is already done. And so intraocular lenses is advancing as the need for the spectacle and intermediate and near vision is escalating. So as you already mentioned, every 6 months we are coming new lenses. So the relative and absolute contraindications are also getting changed day by day, because it's now not a relative or absolute, it's becoming more like a subjective thing and according to the needs of the patient. So I won't go much in detail. We all know we have got multifocal lenses. Earlier it was refractive, then came diffractive multifocal lenses, and now the multifocal bifocals are almost absolute and means very much less in use, and mostly trifocal and EDOFs had taken their places. So this is the in short about the history, because that will explain why we have to avoid these lenses in some cases. Like multifocal refractive optic lenses, it was pupillary dependent because your center of the pupil was for the distance, then near, then distance. So you have to adjust the pupil according to the optical size of the lenses. Then came the multifocal diffractive lenses, in which the anterior surface was the basic refractive and it was aspheric, but the posterior part has multiple grooves for the multiple diffractive functions which perform. But the basic principle was 82% of light is found in two major foci. Approx 41% of light is focused for the near vision and another 41% for the distance vision. But in this, what happens, we are losing significant amount of light, around like remaining 18% is lost. So what happens, there is it causes reduced light sensitivity, reduced contrast sensitivity. So that is the thing that causes major problems post-operatively. So we have to understand that there is no 100% light transmission. But the newer IOLs like Atlisa, Atlara, Acrisoft Panoptics, they claim that they have only loss of light of 14.3%, 14% or 12%. Now we have mini-well lenses also that claims around 95 to 97% of light transmission. So the most of the side effects of the multifocal lenses like loss of contrast sensitivity and like you mentioned that you have to use bright light. So that problems is little bit decreased. So everyone wants multifocal lenses because most of the patients, they are not happy with the glasses to even you have put monofocal lenses, but when you have to again change for near vision, they have to put the lenses, then again remove it. Even they are using progressive lenses, so that is not serving the purpose. But everyone wants, but still we have to keep in mind certain disadvantage which multifocal carries with itself, like reduced contrast sensitivity. So this is what the patient sees. You can see a reduced contrast sensitivity. If the patient is very much nature lover or he is very much keen in photography, he can make out the difference between these two. Then glare and halos, as already mentioned, it's a very, very big problem with the multifocal lenses because that is the most concern they come with, that they are seeing rings all around, which reduces with time. But since in first post-operative month, these are the basic complaints they complain of. These are the glare, halos while driving, but it's more prominent in the mesopic conditions, like in night time, not much in the daytime. Then reduced light sensitivity intensity because of the lesser light transmission. Off-axis aberrations like coma and spherical aberrations that you have already discussed, and require And most important thing is, since the brain has to adapt with the accommodation of the intraocular lenses and the multifocal lenses with multiple focal points. So it requires certain amount of visual cortical neuroadaptation. So according to the studies, it requires almost 3 to 6 months. And in some cases, it may go up to 8 months or 12 months to adapt. So the brain adapts to the multifocal functions of the multifocal lenses. So we have to keep assuring the patients that it will take time for the lens to work in all the ranges and the brain to adapt to it. So first preoperative considerations we should consider is there should be a strong desire. That is the only thing when you go for the multifocal lenses. Unless the patient asks that I really want to get rid of the glasses, I don't want to, you have to see what the patient is expecting from us. Then age is also a major criteria to decide about the multifocal lenses. Since age, most preferred age is 35 to 70 years of age. Less than 35 years, we are implanting in the pediatric patients, but still much studies are still required because the IL power calculation becomes a hindrance in these patients. And in more than 70 years, if you can see that zonular instability is there, and like certain comorbidities, ARMD, diabetic changes, all this increases after certain period of age, after mostly 70 to 75 years of age. So we have to consider the age in preoperative period also. Then functional and occupational requirements, as Dr. Nitin has already discussed. First, you have to listen what are his hobbies. We have to always ask what is his kind of job, what the things he likes to do, because that only gives us the idea that we want to implant a multifocal lenses in those patients or not. If it's a tennis player, piano player, so in those patients, in piano player and the females who are not much readers, but they like to cook and they are multitasking. So they don't want to wear glasses all the time. So multitasking and all, you have to make a habit to ask the patient to have a chit chat with the patient. Then first thing we have to also keep in mind is hypercritical and demanding patients, because these are the patients you have to totally avoid. If their patients are like cribbing and like they are explaining their cataract in a very detailed manner, and they are explaining every complaint, you have to listen to the complaint, what he's experiencing. If he can make out all the finer details, what he is experiencing, that is a red flag that you can't go for this patients for a multifocal lenses. Then biometry plays a very important role. If you got a very high end intraocular lens calculator you need for this multifocal calculation, because you don't want a post refractive surprise in these patients, because cost is involved. So you have to have explanation, then IOL exchange, it becomes more challenging also. So like you should have an optical biometry, immersion biometry, so you have to have perfect IOL power calculation. Then keratometry is important because higher cylinders we usually avoid in multifocal lenses. So you have to see keratometry to see the flat cornea, stiffened cornea, to rule out all these irregular astigmatism. Then corneal topography in corneal ectatic conditions like keratoconus, measure pupillary size, because as Dr. Zain has already mentioned, pupillary size is very much important in EDOFs as well as multifocal lenses. And we have to look for the corneal curvature also. Angle kappa, which Dr. Nitin was mentioning, is very important in multifocal lenses, and we have to look for it. It is defined as the angle between the pupillary axis and the visual axis of the eye, which is very much different from the optical center. Angle kappa was previously used when eye tracy, and we didn't have any measure to measure the angle alpha. So now, since large angle kappas was defined as the value that exceeds half of the diameter of the central optic zone of the MIR, but this angle kappa gets changed after surgery. So we cannot take it in consideration. So angle kappa is now not in use for the multifocal lenses, but we do consider in high hyperopic patients, which indicated that angle kappa was a relatively unstable factor for the implantation of multifocal lenses. Now coming on to the angle alpha, which is more important in today's scenario, it is a difference between the center of the limbus and the visual axis. So angle alpha is taken, like kappa was taken for the center of the pupil, but angle kappa is according to the center of the limbus. We take the limbus as the consideration, because in eye tracy, as you can see, the red cross here, this indicates the visual axis of the line of sight.
Then green plus here, it indicates the center of the pupil, and the blue line is the center of the limbus. So when all these three are coinciding, that means the angle alpha is less than 5, and we can go ahead in these patients for the multifocal lenses. But if these are not coinciding and these points are too far, if the blue cross line, that is optical axis, is far from the visual axis, that becomes a relative, or you may say absolute contraindications on patients because in multifocal lenses, centration is the most important part. The visual axis should correspond to the center of the multifocal lenses because it's zone dependent, and the multifocal lenses are made on the different kind of zones, is designed as like that. So you have to consider the center of the optical center as well as the visual axis. So as I already said, there is no such relative contraindications. It's mostly subjective because most of the relative contraindications, or you can say absolute contraindications, because of the newer IOLs has turned into as is now we are not considering it as a contraindication. Dr. Nitin has already mentioned about the tear film because it is the first refractive surface of the eye. If something is not good with it, like you have a very high-end car and you have a very good engine, but the glasses are dirty or your wipers are not working properly, so you will always have a hazy view. So if you are having a dry eye, but if you are able to treat it, like with a lippy view, or if it's a severe dry eye, you are giving lubricants and all the or you are treating the blepharitis, and if that dry eye is treatable, we can still consider to put a multifocal lenses in the dry eye cases, because it leads to, in dry eye, it leads to dysphotopsia, it decreases the contrast sensitivity, so it becomes a relative contraindication. But that depends on the patient and the doctor also, that you discuss this problem. If it's treatable, if it's the patient is ready to wait, then we can go ahead. Then in pre-refractive surgeries, because in eyes with previous myopic LASIK, the most important factor which we face is during the IOL power calculation. So effective lens position is underestimated because of the flattened cornea, and we get most of the chances are there that we get a post-operative refractive surprise. So we have to be ready for that, and we have to explain the patient also for this thing. But since if everything is counseled and patient is ready, and you are able to, you have a very good IOL masters nowadays, and you are able to calculate almost near emetropic power, then you can go ahead with this in this eyes. But since we all know that refractive surgeries induce significant amount of higher order aberrations. So however, if angle kappa and angle alpha are below 0.5, the total higher aberrations are low, and coma and trefoil are also below 0.4 microns, we can still consider. But this is like a very hypothetical situation because we hardly get that all the situations are matching. Astigmatism is also we have to consider because 15 to 20% of patients with cataracts have a preoperative corneal astigmatisms of more than 1.25 diopter. The cutoff value previously it was considered as 0.75 diopters, but now we have trifocal toric in the market and multifocal toric in the market. We can still go ahead with this astigmatism, but still more than 3 diopters we cannot go, and because more than 3 is not yet available and doesn't give good results. So in those cases, we have to hold the urge to give multifocal lenses to these patients or patients with irregular astigmatism. Now coming to the zonular pathologies. So some pathologies we have to consider like pseudoexfoliation syndrome. But if you have seen preoperatively that there is very much less subluxation, the zonular dialysis is not much, we can go ahead with the use of, and you are confident that you can manage this case with the help of a capsular tension ring, you can still go ahead with the multifocal lenses. The traumatic zonular dialysis. So in these cases also there is very means less than 30 to 40% of dialysis, not much, that can be managed, and you are well sure that you can make a good capsular access, the IOL can be centered, and capsular support is there with the CTR, then you can go ahead with this patient. But still it becomes a relative contraindication for inexperienced surgeons, or if you have a slightest dilemma, better to not to go for in this case, as it may leads to capsular bag and IOL decentration in the future. And that is the primary cause for the dysphotopsia, then reduced visual acuity, contrast sensitivity, and all sort of the problems. And the patient becomes unhappy. Glaucoma is also a controversial topic because earlier we used to avoid multifocal lenses in a glaucoma patient. But because it already affects contrast sensitivity. In glaucoma patients, the contrast sensitivity is already reduced, and it is more reduced than the visual acuity. Even in advanced glaucoma, they are able to reach 6/9, 6/12 central vision, but they have very less contrast sensitivity. So we can consider mild glaucoma or well-controlled glaucoma in medications that becomes a relative contraindication. We can go ahead with multifocal lenses who are very much well aware that they are going to use eye drops properly and their glaucoma is stable. But still, we have to, before the surgery, we should do a 10-2 visual field in these patients to exclude early centration fixation involvement. If any time you feel like, no, the 10-2 is showing some central scotomas or it's going to get advanced, better to avoid in those patients. Higher order aberrations, as already discussed by my fellow colleagues, and they have already mentioned so much about all this. So higher order aberrations are the most problem which multifocal lenses are facing. So in those patients which you see that cornea is these flattened cornea, or in pre-LASIK patients who have undergone refractive surgeries, it's better to measure higher order aberrations by eye tracy beforehand, so you can come to the point of you have a dilemma that you should go ahead or not in these patients. So anterior stromal coma values of more than 0.32 microns and total higher order aberrations greater than 0.5 micron. But still it becomes a relative, because if the patient still wants and he is not affected much by the glare and halos, he doesn't have he or she doesn't have much of night driving, they are more involved in the indoor jobs, and they just want the multi-purpose thing. So they are multitasking, they can able to read, they are able to cook, and screen time, everything, then you can go ahead with these patients.
Dr. Poornima, I request you to please wind up.
Yeah, sure. So pupil is a major issue that Dr. Zain has already mentioned, but in this multifocal patients, we try to avoid in atrophic areas like in uveitis patients, because it already increases glare, photosensitivity, and zonular weakness. And small pupils also affects, small pupil is a challenge because it centration of the multifocal is not there, and for in dim light, it becomes difficult for reading. Then macular and retinal pathology, as we have already mentioned, early ARMD, early diabetic retinopathy, epiretinal membrane, you can still consider putting it. So that's why it becomes a relative, not an absolute. But since if it becomes advanced ARMD or advanced proliferative diabetic retinopathy, that's a big no, and we have to avoid in these cases. Then other considerations are monofocal lens in the fellow eye. So already one patient have a monofocal lens, and the other patient wants to have a multifocal lens in the other eye. So you have to address that. You have to explain to the patient everything, and if still it wants, you can go ahead. But it results better when the multifocal lenses are put in both eyes because of the bilateral summation effect. Ocular misalignment, you have to address first this and the strabismus part also. And monoocular amblyopic patients we try to avoid, but still if the patient is too much demanding and he is too much dependent on one eye and he wanted to be perfect, you can go ahead. But some are the absolute indications which you should never do multifocal lenses so as to avoid the unhappy patient. Like occupational night drivers, you have already, Dr. Nitin sir has already mentioned, and why you should avoid, because they will always be complaining and they will never be satisfied with this thing. Ocular surface disorders also, he has already mentioned that you have to have a very keen eyes, and you have to do a very stringent slit lamp examination to rule out any severe dry eyes, corneal opacity, or any corneal pathology. Pseudo exfoliations I have already mentioned, but if you have a pseudo exfoliation with a very significant zonular instability and it's going to get tilted later, that's an absolute one. You should not go ahead with these patients. Advanced glaucoma, because they have already very less contrast sensitivity, you should not go for advanced glaucoma patients in this. Then I have already mentioned about the retinal and macular disease. Any significant macular retinal pathology you should avoid. Pupillary abnormalities like coloboma, correctopia, because we have discussed that it doesn't correspond at all with the center of the lens. So it's a big no for these conditions. Angle alpha is just a slide is showing that if you have put, so it becomes an unpleasant surprise because the visual axis is not corresponding with the optical axis, and they have multiple problems of higher order aberrations, spherical aberrations, even visual acuity is decreased. So angle alpha, if it's coming if more than 0.4 mm, then better to avoid. This is the eye tracy picture. In this, the first patient, you can see that it's centered. So everything is centered. You can go ahead in this patient, but in this is clearly very much off-centered and more than 4. So avoid in these patients. These, I think everyone is mentioning again and again, we have to avoid in highly critical patients. Highly, they are always cribbing when they come to your chamber and they are cribbing for everything, even like for reception, for you have to avoid in these patients. And lastly, which is the most important thing, is whatever counseling, whatever thing you have done, everything is happy and everything is done. The surgical criteria is the most important thing which you have to consider, because even the patient has paid and you complications are inadvertent. Even if you are very much experienced, this can happen to anybody. So it's the ego should not come in this way, and you should take a step back if you have any of these intraoperative complication like significant vitreous loss, pupil trauma, you have injured the pupil, so you cannot decenter the pupil, iris loss, zonular damage, capsular rexis tear, because the rexis should be well centered, should be well round, it should correspond with the optics of the multifocal lens. So if any of the things is not happening, better not to go for these lenses. Capsular rupture. Thank you so much.
Thank you so much, ma'am, for that exhaustive presentation. Very well divided into preoperative, intraoperative, and postoperative. This is one question I have, that in case you do not have an eye trace, then like what other modules are there for you to measure the angle alpha and the angle kappa? Is there anything else?
Mostly aberrometers we use, or you can with slit lamp also now you can make a count. You have to see from the center of the limbus. You can, with the advanced slit lamps, you can very much because the center optical zone, or during the intraoperative period also, the center of the light will fall near to the optical center. So that also gives you the idea that angle alpha is matching with the visual center or not, because the light where the patient is focusing is the visual center of the eye.
Right. Dr. Nitin, sir?
Yeah, the most important thing I think is intraoperatively also, in spite of measuring the angle alpha and all, is to align the Purkinje images, because that is something which is giving you a very good indication. And also, if you can match the center of the pupil, I use an image guided system, but even without an image guided system, I think it's easy to match the Purkinje images to the center of the central zone of the lens. That is very important. And she mentioned
role of retinoscopy, sir?
In measuring, I think IOL 700 also gives you an angle alpha.
Yeah, and any
IOL
role
Master
of retinoscopy?
Not that I know of.
Dr. Manchu, sir, any role of retinoscopy in measuring angle alpha and kappa?
No, it's a retinoscopy is a very subjective mean. You will not be able to measure 5 degree, 7 degree on that. Not that I'm aware of.
I think this is something for us to research on. I feel that if you don't have an eye trace, then how do you? Yes, I agree. What ma'am said was absolutely correct, that you can do it on the slit lamp, but then that also becomes extremely subjective. It would depend upon what is your streak, the dimension of your streak also. That also will make a huge difference. And what is the exact illumination?
Rohan, if you're going in for a multifocal, if you really want to start with that, doing a topography is very, very important. Very important. And even if you're doing a toric lens implant, to get your axis, not the K reading, your real good axis would come from your topolizer. No question about it. So
absolutely true.
You better have that if you're going for high-end surgeries. And today with the newer machines, everything is given to you on the platter. Everything. There are 7 things together in one machine.
Okay. And sir, when it comes to trifocal lenses, do you choose the power which is exactly emetropic, or do you go with the first negative like we do in monofocal lenses?
It's a very important thing. Very, very, very valid question. It is a lot of your experience which will come in. You'll have to compare your Barrett's, you'll have to compare SRKT, you'll have to compare your past results, what you have had, and then get on what works best in your hand. Because there'll be a consistency in your errors and on your results. Ideally, Barrett's for a synergy, go bang on. For a Vivity kind of a lens or a Symphony, I would have gone on for a -0.1 to 0.25 kind of a scenario. And vivity, if I'm doing a micro monovision kind of a scenario, because for sure they'll need reading glasses if you go bingo. So minus 0.4 kind of in the other eye between the two eyes would help me. That's how I would plan.
Okay. And Nitin sir, your monovision figures, what is it that you leave in the other eye when you put an eye hands? And what is it, what would you leave in the other eye if you put a vivity?
Eye hands, I would go up to 0.75 with a vivity with a 0.5 to 0.6.
Okay.
Again, I do not decide the power of the second eye unless I've seen the results of the first eye. So if the patient is comfortable even with the first negative, minus 0.2 and is reading N6 in the first eye, I wouldn't mind going in for a 0.2 or a 0.3 even with a vivity. But if the patient is reading only an N8, then I would go higher myopic.
Okay.
Your ELP changes quite often. The effective lens positioning changes. You will be surprised. And what Nitin has said is correct. You have to learn from the first eye. You can never, ever be very sure how it is going to behave. The first eye, after a few days, will give you a hint how much of a myopic have you created in that patient.
Yeah. And what about the lens thickness, sir? Like with the bag, how much has it been stretched? For example, if it's a 4 or if it's a 4.7 or if it's a 4.8 millimeter lens, then that also would have a huge effect on the ELP. That also, I guess, something, all these formulas, they do take into consideration. But I think in our own personal hands also, we can take that into consideration, what the preoperative lens thickness of the patient is, because that bag would be probably stretched that much.
So the Barrett's and some of the modern formula, even when you're doing your ASCRS calculator, they ask you for the lens thickness.
Yeah.
And that is what is considered. That will give you additional information. However, the model that Barrett says is a very universal model. So it is minus a lot of, even the posterior cornea doesn't require that.
Yeah.
It calculates
on
in
its
the
own
model which he has created.
In fact, there is a small tick box over there which you can just tick it if you want to include it or if you do not want to include it.
True.
So Zain would tell us sometime about the regression formula and all that, It's too high tech, but finally RBF Hill formula and the regression formula, and this is what it sounds very easy to a mathematician. It sounds very hi-fi to us, but what they are considering is the bigger arc. What they are doing is it's pure mathematical calculation. What says Zain?
Sir, I feel that we don't have the headache. We don't need to have the headache. These guys like Barrett have done it for us, everything. Barrett is still today, the best. But what can get better are the formulae which are based on AI. So you don't have to bother about mathematics. The AI is so, good and it keeps evolving. So formulae like Kane and Hill RBF, they are evolving and they are also very good. So I feel in terms of formulae, we don't have to break our heads at all. These people have done everything for us.
So I'll give you the biggest that Hill has developed. Warren Hill is a personal friend. And what he said while doing all that free, which he did on the Hill RBF calculator, Hill calculator, is the huge international data and that is what is giving him phenomenal AI kind of results. What the newer formula will give, because this kind of data no company also has. What Hill has got.
Absolutely true. And two important things I think which need to be pointed out is, for every surgeon doing a premium IOL, one should know his SIA and keep modifying his SIA. And also one should know his surgeon factor, because that is something which is very personalized and depends upon the type of the surgery. SIA for different incision sizes, SIA for different incision positions is very important to know and feed that. Don't feed the normal company given 0.25 or 0.3, what they do in your IOL master when they come to assemble it initially. You need to keep modifying. SIA also decreases with time, with more experience, with more number of surgeries done. So you need to keep refining your SIAs from time to time.
Thank you so much, everyone. Before we end this, Dr. Mehta, your last words of wisdom to someone who wants to start and dwell himself into the premium IOL practice. Any last words of wisdom?
Just do it. Nike, just do it. The patient and the eye is forgiving, very, very forgiving. despite all odds that we do on the patient, the cornea still remains good. The retina still remains good despite the surgeons. So just do it. Don't think too much. You will learn on the way. Have the courage. But be very, very convinced. If you are not convinced, your results will not be there. Period. That is my answer very clearly in your mind. Whichever lens you are convinced is the best lens, it will work the best for you. Just do it. It's nice. Don't get worried about a few small problems. It's like driving on the road. You can meet with a deadly accident. The complications of a multifocal are lesser than that. A lot is in our mind because we are charging, because the lens is expensive. You are not charging more. But you feel you have been sold out to the patient. Get that mindset out.
Yes, Poornima ma'am, you had something to say?
I just wanted to address that. I think that is the motivation we young surgeons need from you, that we can go ahead with all these lenses in spite of so many roadblocks.
No, there are very few. We keep harping, like the patients who talk about negatives only, never talk about the 98 positive. Okay, even if I see a ring, come on, I tell patient very clearly, in a week, how many hours are there? Or say in a month, how many hours are there? Whatever, 1,000 hours. In 1,000 hours, his driving is not more than 5 hours. So if he is getting advantage for 995 hours, why do you want to crib about 5 hours? Crazy. We are just unnecessarily giving undue importance to things which are not very great, and we are making it an issue. That's my point. If I'm not God, I'm not given a cataract, I'm not given trouble. I'm trying to solve it in the present situation. I'm not the lens manufacturer. I'm not the designer. I'm a poor surgeon. I'll try and get you the best. Your choice, how your eye accepts. Good luck. We tried our best possible thing.
I think cost is the factor.
Don't think too much, just do it.
Back.
Cost is only in your mind. Tell me how many of your patients are having an iPhone or a new Samsung. How many of them are having a good car with them? Air conditioner? Don't even think. It's in your mind. And I keep telling this again and again and again and again. Which was a new thing Ron came up 2 days ago. Something costing 2 lakh. And there are more than 5 lakh bookings which happened within first 15 minutes.
World Cup tickets, sir.
Good one.
Sold out in 15 minutes.
नवनीत माइक्रो को बताना है कि हम लोग को वर्ल्ड कप टिकट देने वाले हो कि नहीं आप लोग. नवनीत छुप गया है. नवनीत. So good. Thank you, Navneet, for being there always and stand by. Go ahead, Pooja. Over to you.
Thank you so much to get such words of wisdom from our esteemed speakers. I'm sure that this webinar has helped all the youngsters who are even thinking and doubting themselves whether or not to go into a premium IOL practice. And for those who missed out, it's saved on our channel for future references and re-references. We will see you next month back for season 2, chapter 5, something which is extremely important, myopia boom. We would also like to thank our Microvision team, Mr. Navneet and Mr. Ashok, for all their help at the back end to run this event smoothly. Thank you all. See you all next month.
Thank you.
Thank you.
Bye, Pooja. Bye, Rohan. Bye, Himanshu.
Thanks to everyone.